Good evening, everyone. First of all, I thank Oncology Club Bangladesh and Radiation Knowledge for providing me the opportunity to be part of this program. Today, my presentation is going to be treatment planning and plan evaluation in breast radiotherapy. Before start with my presentation, first we need to understand what is the rationale behind the whole breast irradiation. This is a Lancet publication published in 2011. Like after BCS, radiotherapy halves the rate of which the disease recurs and reduce the breast cancer death by 1/6. Okay, that is the main reason why we give whole breast irradiation. If you talk about 3D-CRT is obsolete, in the modern era of radiotherapy, 3D-CRT is obsolete, it's a big question. No, it's still very much alive. It can still do a great job for us. The main advantage of 3D-CRT is its availability around the globe, and the cost of the treatment compared to the modern radiotherapy is comparatively much more cheaper than the advanced techniques. Better understanding of the process of the 3D-CRT is a big advantage of using the 3D-CRT for most of the cases, and it's a easier plan, and dose verification is also an important point why we 3D-CRT is alive. You may not compare an average 3D-CRT plan with a good VMAT or IMRT plan, but in many cases, a good 3D-CRT plan can be as good as an average IMRT or VMAT plans. Radiotherapy PTV margin bases are very important to understand. Okay, the important thing is if you talk about you have a CTV radius of 5 centimeter and you give a 5 millimeter margin to make your PTV, you have a volume of somewhere around 697 cc. If you're able to reduce your PTV margin just instead of a 5 millimeter, you are able to give a margin of 3 millimeters. Your volume is somewhere around 623 cc, which is a 10.6% reduction in the volume of your PTV. Every 1% of irradiation volume means up to 3% of TCP and NTCP ratio. So that we need to use an adequate margin so that if you overestimate the margin, you're going to irradiate a more volume, and if you underestimate, there is an enough chance of you're going to have a geographical miss. So that we need to give an adequate margin. We need to understand all the uncertainties in radiotherapy, and margin has to be done accordingly. If you want to do a good 3D-CRT plans, a medical physicist need to have a complete understanding of an LINAC and the treatment planning system. For an example, the kind of a LINAC what we use, you need to know in and out of all these parameters. Example, if you have an asymmetric jaw in a variant machine, okay, you need to know that what is an exact override length. Okay, like my X jaw can override by 2 centimeters, my Y jaw can override up to 10 centimeters, and we need to know the minute details about your treatment planning system and the dose calculation algorithm. Try to explore all the beam energies available, like especially for the breast case, like it's not only a 6 MeV beam, you need to incorporate all the beams available to get a very good quality plan. Utilize most of the MUV fire. Okay, that's a very important concept we need to understand. Each MU you need to utilize. Every millimeter is important. As I showed in my previous slide, every millimeter is important, so that give like adequate margin, as well as don't overestimate your margin. Okay, don't give too much of a margin, give adequate margin, and use proper normalization. And plan simplicity is one of the important thing. Don't think about yourself when you do a plan and you have a good quality plan. It has to be very simple for a technologist and radiation oncologist to understand and deliver the plan. Always you need to have a technical appreciation of what we are doing. If you try to follow all these parameters, then you'll obviously your plans will become better and better. What is the greatest uncertainty in radiation oncology? As we know, there is a lot of uncertainties involved in an radiotherapy treatment. The main uncertainty still with all these modern equipments and modern imaging systems, still our target delineation becomes a major uncertainty in radiotherapy. As if you talk about dosimetry setups and set up other motions, everything can be done within 3%, 4%. But when the target uncertainty is really a big task when it comes into the radiation oncology. For an example, if you talk about the target volume contouring variation, okay, so that it's a typical case of a breast, there is a lot of inter-absorber variability, so that proper guidelines are available, so that it makes our life easier. But still, with using these guidelines also, each and every patient is unique. To go according only along with the guidelines is also very difficult. Each patient is unique, so that the contours variability will be there, but these guidelines will help us to make our contours more consistent. Contouring guidelines, there is a variation. Like, for an example, typically, if you talk about RTOG, ISTRO, this is a typical example of an regional lymph nodes in the breast cancers. If you can see all these protocols, there are an, inter-variation between these protocols, RTOG, RADCOM, PET, Labrador, and ISTRO. You can see there is a variation between all the level of lymph nodes has been delineated in the structures. So that there will be a variation in the guidelines will be there, but still, it's better to follow the protocols to avoid these uncertainties in the contouring as much as possible. Like before I getting into the 3D planning, just I will give a little bit of a brief, like a few slides about the 2D planning. Okay, normally, like in our subcontinent, like around 50% of the patients in the breast, get a 2D based treatment. So that, just I want to emphasize in my presentation a little bit about the 2D planning. Normally, if you take a 2D planning, this is a typical patient, like, what we do is we do an superior and inferior marking as well as a medial and lateral marking. And what we do, like, for the, this is what we do for last 2-3 decades for a 2D planning, using a lead wire or an a plaster of Paris mold. Just you take shape of the breast, and we can use an separator or an L-shaped scale to measure these distances. So that for an example, like you got this measurements using the L scale and the breast separator, and we got the midline to the lateral distance around 19 centimeters and the vertical distance around 17 centimeters. By using this formula or using a separator, we can get the value of this A, B, and C, so that we got the separation of 20.5 centimeters. So that if you want to identify the gantry angle, like optimal gantry angle for this particular patients, like still we'll go with the basic maths about this opposite and hypotenuse, so that we know these values by all these measures, like so that for a tan theta, like opposite by adjacent, we'll take the opposite and adjacent, 17 by 19, which is 0.895, and you want to find the angle of this, that should be the tan inverse of 0.85, that is 41.85, so that my left tangential angle will be 221.8 and my medial tangential will be 41.8. This is a simple max. In an alternative method, you can use a protractor directly to measure the angle of the field. Okay, let us come into SST or SAD. Normally, we always prefer an SSD treatment, because most of the times, if you use an SSD technique for each and every field, you have to get in, you have to set up the patient, and you have to treat. So that most of the times we prefer an SSD treatment, so that SSD treatments are obviously it's time saving. You can increase your throughput. So that always most of the centers, they follow an SSD treatment for breast cancers, but still some of the centers still follow SSD technique. And the other important thing is when you use the breast fields, when the point of normalization is also very important. I think I'll talk about this later in my slides. So that typically, like when you have a breast, normally we take from the midline, like you take something about 1.5 centimeters above, and just make a normalization point, because normalization point is very important for the dose calculation purpose, that I will talk in my later slides. Let us get into CT-based planning. Why CT-based planning is important? CT-based planning will help us to evaluate the plan quantitatively and qualitatively. CT-based plans will help us to visualize the OIR doses and PTV coverage in graphical and statistical representation. And CT-based plans really help us to optimize the treatment plan, because once you do a 2D planning, we don't know where the hotspot is happening, whether we are given a proper beam, like proper beam selection has been done, so that it will help us to identify, optimize the treatment plan, and it will help us to improve the dose homogeneity within the target and reduce the doses to the OIR. So that most of the times, like in our subcontinent region, we always need, we get always T2, T3 disease, like with most of the times we have to prophylactically, or sometimes we have a node positive cases, we need to give an regional lymph nodes in the breast, we have to treat. So that most of the times we follow an like a 3-field technique, supraclavicular field along with the axilla, as well as the 2 tangential fields. So that most of the centers follow, if they have an asymmetric field in their treatment missions, we follow a single isocenter technique, so that a single isocenter for both the tangents and supraclavicular field is being done, and tangents of an off beam blocked superiorly and supraclav half beam blocked inferiorly to avoid the overlap of the fields. Collimeter of the tangent fields typically set to 0, and MLC leaves are drawn to block the lung and heart if necessary. So that the isocenter position of the breast treatment is very, very important. So that what is the like an ideal position to keep the isocenter for a single isocenter technique? Normally, it is a few millimeters below your supraclavicular node, and where the PTV, or otherwise, you also has to consider where the PTV changes drastically. These are the two important consideration you have to take. Once you take your isocenter slightly lower, the problem is the supraclav field will give an enough dose to the apex of the lung, which is not good, because when you try to see the combined three field, the dose distribution, the apex of the lung is receiving a lot of dose. So that you try to use such as when the supraclavicular node ends, just try to just start your keep the isocenter there. That's an ideal like position where you can place the isocenter. If you think about a single isocenter technique, this is a typical field. What we do, we try to treat the level 1, level 2, level 3 axilla and the supraclavicular node, and we can shield a little bit for the esophagus and for the humerus head. So that this will be a typical supraclavicular field, and this will be the typical tangential field. How it looks, we can shield a little bit of a lung over here, and if it's in left breast, you can shield the lung as well as the heart. So that this is a typical room's eye view, how a single isocenter treatment looks. And okay, most of the times, 50% of our subcontinent populations, we don't have an asymmetric collimators, because we used to treat with an cobalt machines, because cobalt machine is very popular about our subcontinents. So that dual isocenter techniques becomes an it's a common practice in breast cancer. So that what happens here is, like, when you try to do a dual isocenter, the beam divergence, which is going to create an hotspot between the supraclavicular and the tangential field. So that we need to give an attention over there to avoid this hotspot, because if you want to try to deliver a 50 gray, and this hotspot is going to be more than 90 gray and 95 gray, which is going to be very hot. So that we need to be given proper importance to solve this solution. So that what we do is, when you do a dual isocenter, like, we try to shield using an MLC, if for typically for an one isocenter for the breast tangential, for a separate isocenter for the supraclavicular field, in order to match the superior border of the tangents or an inferior border of the supraclavicular field, a couch still can be applied. Or if you want to do it with the tangential field, you can just apply the MLCs just to cover the tangential field. MLC leaves are used to, as it's shown in the diagram, you can use to match the superior supraclavicular field. The other way of doing it is the couch rotation technique. As simple as it is, it's an easy way of doing it. You tilt your couch rotation so that you can match both the tangential fields to provide the junction in the supraclavicular field. But when you try to do the couch rotation, try to make sure you're using an asymmetric field, using an in the cobalt or in any linear lattice where the asymmetric field is not possible, so that you can use a half beam block, or using a block, try to block it for the supraclavicular field with an asymmetric field. So that this is how the dual isocenter looks like. You treat with a single isocenter for the supraclavicular field, and you do a couch rotation and try to match both the beam divergence, and use an asymmetric field for the supraclavicular field. Okay, what does the dose coverage looks when we treat with an older treatment techniques? Okay, to forget about, we don't do any kind of an delineation. How it looks? Okay, we know the level 1, level 2, level 3 of axilla and the supraclavicular node, or most of the times we used to take it as a regional node irradiation. So that if you try to put a typical field like what we do, and we try to normalize at somewhere around, if you don't delineate, we normalize around 2 to 2.5 centimeters below the surface, and we do the dose calculation and we normalize at 2.5 centimeters. So that this is a paper published by Fontanilla in the Practical Radiation Oncology Journal. Like, if you try to give a 50 gray prescription, and if you see the 45 gray coverage, a level 1 lymph node will be covered by 84% by 45 gray, and 88% by the level 2, and 93% by level 3, and 84% by the supraclavicular nodes, and 80% by the intermammary chain nodes. It's good, we importantly to remember that, we have a very good outcome with this, but perhaps we can do it better when we define the contours while keeping in mind the normal tissue toxicity. And the other way of doing in high tangents, if you try to do an axilla level 1, level 2 coverage, and if you talk about high tangents, normally we are able to, if you see the 45 gray in a high tangent beam, the axilla is covered by 78%, level 1 axilla is covered by 78%, and level 2 by 21%. And the V20 of the left lung is around 9.75%. But when you try to use a customized tangents, where if you delineate and try to just cover all the levels, so that in the level 1 which can be covered by 100%, and level 2 can be covered by 95%, so that customizing with the contours we are still able to improve the nodal coverage much better. There is a slight increase in the V20 of the left lung, but still, like if we are able to give, if there is an indication for the level 1, level 2 levels to be treated, we can use and customize tangent to cover this. See, like, I'm talking about a little bit more about the regional lymph node, because it's an educational session. Our case for the planning competition doesn't involve regional node irradiation. It's only a whole breast. Mr. Ahmad will cover all the component about the dosimetry criteria and everything. But still, as an educational event, I try to cover all these regional lymph nodes and the whole breast irradiation, including boost, in my presentation. If you think about the portion of the field, normally what we do is most of the times we underdose the level 1 axilla. Okay, so that if you want to do proper delineation, and probably we try to cover the level 1, this is how the field looks, and normally we need to compromise a little bit of the humerus head. And the other thing is, when you talk about the supraclavicular field with an axilla field, normally when you try to cover the level 1, level 2, level 3 axilla fields, normally a single field with a small gantry tilt, which is going to give an enough dose to the apex of the lung. A small posterior axilla boost with a small weighting of the field will really help us to reduce the doses to the lung, and it improves the dose coverage to the level 1, level 2, 3 of axilla. So that proper utilization of posterior axilla beam, where you require to treat the level 1 and level 2 of axilla, a posterior axilla boost will really help us. Okay, if you want to treat only the level 3 and supraclav, normally the posterior axilla is not required. But when you try to treat level 1, level 2, if there is an indication, probably a posterior axilla boost will help us to improve your homogeneity of the target coverage, as well as to reduce the dose of the apex of the lung. Let us come into the whole breast, open beam versus the wedge beam. Obviously, in breast, the one thing we need to understand is the wedges here are used as a tissue compensator. Okay, because of the irregularity in the breast contours, we are trying to use this as a compensator. Okay, whereas in other fields where you have an anterior and the two lateral fields, we are using for the because of the beam divergence, we and the beam stoppage, we use it. But here, if the main reason what we use is just to compensate the lack of tissues there. So that ideal wedges, normally we try to use it something about 15, 20, 30 degree wedges are ideal to just to compensate for the breast irregularities. For an example, if you don't use an in the tangential field, if you don't use a wedge with a wedge versus an open beam, you can see a big hotspot happening with an open beam. And if you have a wedge beam, you have an homogeneous distribution around the target. So that wedge is an important component to have an homogeneous distribution around target and reduce the hotspot. And the effect of a collimator rotation is also an important component. If you don't rotate your collimators appropriate for your lung and the heart, it is really going to increase the dose of your heart and the lung. So that for an example here, like what we did is, if you don't do an appropriate collimator rotation for to just match the breast, you can see the increase in the dose to the heart and lung is appreciable when you don't use enough collimator rotation there. So that it always, when you try to do an whole breast irradiation with a single isocenter, it's very difficult to do an collimator rotation. But when you treat only the whole breast, we try to use the collimator rotation as much as possible, or otherwise use an MLC to shield your lung and the heart as much as possible to avoid the toxicity to the lung and heart. And this is a typical contour for breast cancer. We have a whole breast. We talk about the lumpectomy cavity. The whole breast, it's our CTV, and you have a heart, like a heart and the lung as also part of an OAR. Okay, this is how the sagittal view looks. And with the recent advancement in the imaging, there are other components. The heart is, we take it as instead of taking a whole as a heart, there are other components like LAD, left ascending anterior descending artery, and left ventricle plays an important role in the cardiac toxicity. So that if you are able to give an good contrast scan during the breast, you can able to define the different chambers of the contours. And doing an treatment planning, a small gantry tilt can avoid the divergence of the beam. If there are machines where there are asymmetric collimators are not available, so that you can do a 3 or 4 degree tilt to avoid the divergence of the beam. For example, here like you have a divergence of the beam, and if just doing a 2-3 degree tilt, we are able to avoid the divergence of the beam, which will avoid reduce the doses to the heart and lung. And this is a typical example how it looks like. If you do one beam, like you can see that there's a divergence which is going to the heart, and without this, obviously we are able to reduce the low dose volumes as well as avoiding the lung as well as the heart in the divergence of the beam. So that doing an gallery tilt, we are able to just we did an dosimetric study, and we are able to reduce the heart doses. The divergence beam which is going towards the heart can be reduced by giving a small tilt or using an asymmetric field collimators. So that independent jaws can be used to create a half beam blocks, or half beam blocks can be avoided for the divergence of the beam. If not available, then you can use a small 3 to 4 degree gantry tilt to avoid the divergence of the beam. The other very famous technique what we do for to do an homogeneous irradiation of the breast is doing a field in field technique. So that you do a dose calculation and just convert your isodose lines to the structures, and try to shield the volumes, just doing a small weighting and just try to irradiate and just make the homogeneous as distribution as homogeneous as possible. And in the other way around, you can also give, whereas if sometimes the separation of the breast is too much, if there is an underdose on the mid around the midline, you can also open a small pocket of a dose and giving a small weighting, and you can improve the dose homogeneity around the target. And the other important thing about the PTVs when you try to come into the plan evaluation mode is, we normally we consider the entire breast as our target volume, and we give a PTV margin for the setup errors, so that most of the times our PTV just goes to the skin. But most of the times in the lumpectomy cases, our skin is not the target. So that normally the RTOG guidelines, which give a concept of an PTV evaluation, which excludes the bony thorax from the anterior part of the rib surface, you can see here, as well as it crops the structure something about 5 to 6 millimeters from the skin. So that when you do a DVH evaluation, okay, like you can see, like if you don't crop it, like it's a 3 millimeter from the screen, you can see it looks clearly under dosage of the PTV. But once you crop a 5 millimeter, you can see it's much better. Once you see a radiation oncologist see this kind of a distribution, probably he will not like it. So that a cropping in 5 millimeters of the PTV from the skin will really help us to evaluate the PTV, because skin is not our target. But you try to give an enough flash distance, don't compromise on that. But when you try to evaluate the PTV, just try to crop it 5 millimeter from the skin, because most of the time skin is not our target in the whole breast irradiation. If there is any skin infiltration, you need to be considered this. But if there is no, in most of the times, if it's a skin infiltration, it become a T4 disease. And if there is no skin infiltration is there, always you can generously crop 5 millimeters, and you can evaluate the PTV when you do an plan evaluation. Plan normalization is another important concept. Once the dose calculation is done, we need to do the dose normalization to some point or a volume. There are enough options available in the different planning system. The point of normalization can be anywhere in the dose calculation grid, but it's a user choice. But the normalization point should be represent the target dose. Normalization point should avoid in the dose gradient region. Normalization point should be avoided in the tissue air interface. These are the important things to be considered when you do a dose normalization. And points to be considered for an normalization is, always check the global maximum. For a 3D-CRT plan, always it's better to keep your dose max less than 107. But in high MRT, yeah, it will be very difficult, but try to keep it within 110 to 115%. The location of the hotspot is very important. With using a field and field technique, or using a small field within weighting, you can preferably try to bring it within your area of interest, that is your CTV. Or if there is the boost volume, you can bring your hotspot inside the boost volume. And target mean or median dose needs to be considered, because this represents your target dose. So that if the target mean or a target median dose is close to 100%, it's really good. You have a very homogeneous plan. Value-based normalization is commonly used as breast when we have a supraclavicle along with the whole breast. The problem is when you try to use a value-based normalization, it's very difficult to do a secondary MU check manually. So that it's better to have a point and normalize at that particular point, so that if you can use an off-axis ratio and able to do a secondary monitoring check, and our TPS calculator and manual calculation check are within 3 to 4%. And always it's better to create a reference point and normalize at that point, will allow us to do enable to check the second MUs again. These are the dose constraints by RTOG, like for the heart, like normally we take V5 should be less than 40%. If it's a left-sided tumor, it should be less than 50%, and V20 should be less than 20%. There are different guidelines talks about different dose constraints, and if you talk about cardiac deaths and after breast radiotherapy, and the cardiovascular risk factors predicts for the cardiac death after breast radiotherapy, and the cardiovascular risk factors should be modified in breast cancer patients. The radiation-induced cardiac death at 10 years is low if the mean dose of the heart is less than 3.3 gray. And there is another data which is talks about the LAD, left anterior uh, artery, descending artery, dose which is less than 45.4 gray. The studies are needed to evaluate the heart and LAD constraints in the city planning era, because always we talk about the mean dose of the heart, but now with the mean heart dose is not enough to predict with the confidence individual patient's dose to the left ventricle and coronary arteries. In particularly the LAD, for the precise radiotherapy induced cardiac toxicity studies, it would be necessary to consider the distribution of doses within the cardiac substructures rather than just to the mean heart dose. So that the same model, when you try to evaluate the boost volume, also try to crop 5 millimeters from the skin to evaluate the PTVs. The boost techniques can be done with a lot of other different techniques, like by electron boost, by implants, by 3D CRT techniques, or with a high-end technique like IMRT and VMAT. But electron plays a major role when it comes to like electron boost. But we need to have a clear understanding of an electron PDD parameters to define, to go proceed for the electron boost. Like if you talk about the important parameters here is the therapeutic range, RT dash and RT. RT dash is the the range of an electron of a particular beam where it reaches the therapeutic range during the buildup, and RT is after the buildup. So that these two parameters are very important. When you have a disease very close to the surface, then you have to choose the energy appropriately. Like if you have something about, if you consider the RT dash as 5 millimeters, don't try to, you have to use a bolus to bring your RT dash on the surface of the skin or the surface of the target. So that RT dash and RT is very important. And RP is also a very important parameters when you try to think about the OARs. Your OAR should fall up, after the RP range. So that these three parameters need to be considered when you choose an electron energy for the electron boost. For typically, the therapeutic range is 1/3 of your energy. So for normally, if you use a 9 MeV, the therapeutic range is something about 1/3 of the energy, which is 3 centimeters. And the RP is something about half of the energy, which is something about for a 9 MeV, which is something about 4.5 centimeters. And electron beam obliquity is an important factor, so that we have to just rotate your gantry just perpendicular to the incidence of the beam. It has to be perpendicular, so that you can see that there's the dose to the lung can be avoided. Just give an appropriate gantry angle, we can cover the target very clearly. And obliquity also we have to consider. When you increase your obliquity, the hotspot in the surface is also going to increase. Just for an example, if you're going to increase your oblique incidence, which is going to be around 60-70 degree, which is going to increase your hotspot more than around 120 to 130%. Let us talk a little bit about the breathe hold technique. And breathe hold is like when you try to take a deep inspiration and hold the breath, what happens is like your the heart will be pushed down and your lung has been expanded. So that for an example, like this is a typical breathing cycle. Like when you just set and lower and upper threshold during the CT scan, then the patient takes a deep breath, then normally the surrogate markers like automatically goes here and it holds and it start taking the CT acquisition, as well as the treatment procedure are also the same way when it goes to the upper threshold and the lower threshold once you have a beam on. Let us see the distribution, how it looks like. This is a typical example of a deep inspiration breathe out. Like you can see amount of an heart is involved. When you have a deep inspiration, the lung has been expanded and the heart has been pushed. Totally your heart dose has been reduced like substantially. So that you can see here, there isn't completely that heart has been come out and the amount of a heart irradiation has been reduced with, so that deep inspiration breath hold has been an encouraging results for the left-sided breast cancer. And we need to see the choice of the selection of the patient is very important. The patient able to hold the breath for 10 to 20 seconds is more important. So that for an example, like in the DVH, you can see, and you are able to reduce the heart doses substantially, and we are not able to increase the doses to the lung, but still there is a substantial, not substantial, but we have a reduction of the lung doses as well. The dose volume constraints, when we talk about the hyperfractionations, the heart, we try to keep the mean dose less than 3.2 gray, which is defined with the RTOG 1005 criteria. And there are other constraints which we talk about the hyperfractionation here. Okay, so that when you do an whole breast irradiation using an hyperfraction, you should consider at least do a city-based planning, not an 3D CRT plan, not an 2D manual planning. It should be avoided because we cannot understand in the 2D planning what is the doses to the OAS, how good the PTV coverage, what is the hotspot. So that it should be completely avoided if you don't go manually for the whole breast hyperfractionations. And PLAS should be homogeneous as much as possible with the help of wedges, field and field techniques. And the volume of the PTV, more than 105% of the pressure should be as less as possible. Volume of 100% of the PTV should be ideally 0%. The mean heart dose should be less than 3.2 gray. The ipsilateral lung volume V16 should be less than 15%. If you're not able to restrict the OAR doses and the PTV homogeneity, better to go with the conventional fractionation. Okay, to end my presentation, there are a few cartoons just I want to show you. The patient, the cured from the breast cancer but died of cardiac toxicity. It should not happen. And again, there is another scenario. Doctor spared my heart and lung, but he also spared my tumor. Okay, so that be careful, and thanks for your kind attention.